Hi everyone, this is Dr. Jaisy Vargas. I am recording this video for APRNs and nurses who are requiring additional help with understanding the medications, the clinical features and characteristics or pathophysiological mechanisms on patients who has female reproductive disorders. You'll see these type of patients in the clinical settings, especially the primary care and the OBGYN clinics. So I have formulated several slides on the different types of clinical conditions that you will need to treat at the primary care settings, and also when would you refer them to the specialist. There will be questions that you will see on the state board exams also will be posted on and off. So pay attention to each of these slides carefully. Here we go. The first slide is about female sex hormones and their functions. So as you know, there are estrogen, progesterone, prolactin, oxytocin, follicle-stimulating hormones, luteinizing hormones, and testosterone. A lot of times I've seen questions on the LH, the functions of the LH because of the ovulation-related problems. You'll see a lot on the questions. Estrogen is another one that you will see because it affects the endometrium. It also causes a rise in luteinizing hormone. So testosterone, you will see that with patients with the PCOS, obesity, depression, especially in the perimenopausal woman, who will come with all these symptoms, and younger teenage, post-teenage kids, adult, before adolescence, they will come and discuss with primary care the issues they have gynecologically before they are referred to the gynecologist. Progesterone produced by the corpus luteum after ovulation and causes the lining and uterine vascular mechanisms. So it actually promotes the vasculature in the uterus. The main function is it prepares the uterus for fertilization, and at the same time, it suppresses the estrogen release, especially after ovulation. Prolactin is another hormone that is responsible for breast milk, and with the oxytocin stimulation, it increases the blood supply to the breast bud, especially during pubertal changes in the females. Oxytocin is produced in the brain. It regulates our mood, emotions, and also it engages in the mother-infant bonding after birth. Follicle-stimulating hormone, you will see that related to menstrual changes in females. If there's questions related to menstrual disorders, pay attention to FSH. Related answers, especially it is responsible for the maturation of ovum prior to ovulation. The next slide is a summary of the common hormones that you will see on the questions. Estradiol, it's responsible for breast development, maturation of vagina, uterus, ovaries, and the fat deposits in the female reproductive organs. Estrogen, again, it's a proliferative hormone. Testosterone is responsible for male and female, especially in the male, testis, scrotum, and penis. And then there is a hormone called inhibin. It inhibits the release of the other hormones. And there is progesterone, which is a secretory hormone, and it maintains pregnancy. This is another summary of those two hormones, and I want you to pay attention to the FSH and LH. And I'm not reading through the slides, so pay attention to every single point. You will see a lot of questions related to those points in pathology, pharmacology, and state board exams. You'll see a lot of times questions on endometriosis. Pay attention to every highlighted areas. Know that it is an estrogen-dependent condition. It also works outside the uterine cavity. And the hallmarks to diagnose that is the 5 Ds: pelvic pain with periods, presence of dysmenorrhea, dyspareunia, which is painful sex, chronic pelvic pain, diarrhea, constipation, and painful defecation. And how do you diagnose the endometriosis? By laparoscopic treatments, tests. I'm sorry. Due to inflammatory and estrogen-dependent nature, it causes a lot of pelvic pain and infertility in females. So you'll see questions related to that, maybe a complication of endometriosis, maybe a gold standard for treatment, maybe how do you diagnose them, what are the symptoms you will look for. So pay attention to this slide. And there is an article that I have attached to this for detailed information on these. The key points to remember is know the meaning of endometriosis, and as a nurse practitioner or an RN taking care of females with these symptoms, know the mechanism behind that, the signs and symptoms, the severity of the pain, and sometimes we presume diagnosis based on the clinical findings, but make sure you send the patient to have a laparoscopic evaluation to confirm the diagnosis. Galactorrhea is another term that you will see on exams. It's a production of milk from the breast unrelated to pregnancy or lactation, and also 1 year after stopping breastfeeding. That can be non-lactational causes, and that's why it's called a galactorrhea. The hormones involved in these mechanism is prolactin, estrogen, and TRH, thyrotropin releasing hormone, not TSH. Key points here is hypothyroidism can cause increased secretion of hypothalamic thyroid releasing hormone, and that stimulates the pituitary release of prolactin. It also can be side effect of medications like Tagamet. It's an H2 receptor antagonist. Cimetidine or Tagamet is another word. The galactorrhea occurs when patients who are on antipsychotic medications. It can be a hyperprolactinemia. Patients with a pituitary adenoma will have hyperprolactinemia also. So it's always advisable to do an MRI of the brain to detect if there is a pituitary tumor that is causing this. The hallmark of pelvic inflammatory disease, I want every RN and APRNs to know this because you will see questions on these all the time. The hallmark is a triad of uterine, adnexal, and cervical tenderness and lower genital tract inflammation. That's the key point. I have highlighted this a couple of times, so pay attention to that. The common causes of gonorrhea and chlamydia, pathophysiology of pelvic inflammatory disease, and they will put these as answer choices, so don't miss those answers, okay? Common causes, look for underlying STDs. Gonorrhea and chlamydia are the two that you will commonly see. How do you diagnose this? Gold standard again, laparoscopic exam. And how do you treat it? The 3 drugs that are used, and you will see these in the exams: doxycycline, azithromycin, clindamycin, and metronidazole. You have to use this in combination to treat them because you're looking at 2 of those STDs that is causing the pelvic inflammatory disease. These patients have extreme sensitivity to that pelvic area because the pain is very limiting. They will be on bed rest. They won't be able to get up and walk. They will have a hard time urinating and defecating because that whole pelvic area is super tender. The key word sometimes they use on the exam questions is cervical motion tenderness. Very important. Think pelvic inflammatory disease, cervical motion tenderness. There are 2 types of menstrual disorders that you'll see on exams: primary and secondary amenorrhea. Primary amenorrhea is absence of initiation of menses. Secondary is absence of menses in a previously normal menstruating female. Pathophysiology is functional hypothalamic amenorrhea. One of the characteristics is the abnormal secretion of hypothalamic GnRH, which is the gonadotropic hormone. Low or below normal levels are seen on the LH concentrations, also luteinizing hormone. So sometimes you will see absent. They have abnormal follicular development, and also they will see a very low levels of estradiol. So amenorrhea, key points on the left side, and primary dysmenorrhea. So there's 2 different things. Release of prostaglandins are the key factor in dysmenorrhea. Amenorrhea, think hypothalamic hormones, which is gonadotropic and luteinizing. In dysmenorrhea, prostaglandins and vasopressin, two of them. The two common causes of the secondary dysmenorrhea is endometriosis and adenomyosis, usually seen in premenopausal women. And here's an article that I attached for detailed information on those two diseases. But these are the key points on these two. Know the difference between primary and secondary on both amenorrhea and dysmenorrhea. This is a little details on amenorrhea itself, the same repetition, but some students, they find this beneficial because of those visual appeal. The key point here is secondary and amenorrhea. The most common cause is pregnancy. You'll see these on questions all the time. An absence of menstruation, because these people are already menstruated, and after 6 months or 1 year later, they do not have periods. So think pregnancy first. And the other causes are anovulation and ovulation, dramatic weight loss, malnutrition, and relation to thyroid diseases. And polycystic ovarian syndrome is also one of the causes. And then they may have perimenopause. I had patients in my clinic who were menopaused at age 36. So look for causes outside pregnancy also. This is a repetition of the slide that I distributed earlier. Pay attention to the clinical examples on the slides. The other one was small enough to enter all these details, so I have developed another one. So secondary dysmenorrhea, look for the diseases. You may see case scenarios with these examples, so don't miss those choices. And on primary, again, prostaglandin is the key word. Endometrial prostaglandin production is high in primary dysmenorrhea. So the key points are listed here with age differences on menopause and perimenopause. These are all under the menstrual disorders. So perimenopause, you will see related to dysfunctional bleeding. That's the key point here in the slide. Menopause, you have to know the time. It is a point of time in which for 12 months after the last period between age 45 and 55. That's the key word there. In perimenopause, no, there is dysfunctional bleeding. They may have large amount of blood loss from blood clots. Patients also have high risk for iron deficiency anemia. And now look at female cancers, breast cancer and cervical cancer. First sign is a non-tender palpable mass or a thickened area, which indicates invasive cancer of the breast. In cervical cancer, look for ages between 16 and 18, and the type of HPV is also like P16, P18, you know, those are the patients who have high risk for this cancer and also better chance for them to get a good prognosis. So the keyword here is the infection with high risk oncogenic HPV. HPV virus can be both these P16 and P18. Make sure you know this by heart because it is a precursor of precancerous dysplasia. You'll see that in the biopsy report after pap smear, and that indicates invasive cancer of the cervix. Looking a little bit more detail of the HPV, human papilloma virus. It is used as a screening for young women receiving treatments on their on their cervix. These are patients who are at high risk. Previous efforts at early screening resulting in young women receiving treatments on their cervix. The treatments usually destroy or remove the normal cervical cells, which causes an alteration in the integrity of the cervix itself. And that results in preterm births in women treated without decreasing the cervical cancer rate. So it's the leading cause of oropharyngeal cancer in 2022 and 2023, HPV. So pay attention to these keywords because you'll see these on exams. And another key point here is smoking shows increased risk for persistent infection and causes cervical cancer later on in their life. Remember, we talked about the oncogenic type of HPV, that's 16 and 18. It is the precursor for developing precancerous dysplasia. causing invasive cancer of the cervix. Another common disease that you will see under female disorders is HSV, genital herpes. It is an STD caused by the herpes simplex virus. So you had to know there is type 1 and type 2, which is HSV1 and HSV2. Don't get confused with this. So there is a detailed explanation on the description on both and how do you detect these antibodies. One of the gold standard for detection of HSV antibody is Western blot test. It differentiates the HSV1 with HSV2. They also do a PCR blood test to distinguish them with active infections. So pay attention to every single sentence of this slide. Ovarian cancer, another common one that you will see after women over 40 years of age, especially with early menarche, late menopause, nulliparity, and then use of birth control or fertility drugs. Patients also have a familial component to the ovarian cancer with those who has family history of breast cancer susceptible to BRCA1 and BRCA2 because of the mismatched repair gene syndrome, ANP-BC syndrome. They also have low progesterone levels, which not usually associated with ovarian cancer. That's one of the key words to remember. The low progesterone levels are not usually associated with ovarian cancer. Leiomyomas, I've seen this a lot in the oncology clinic, common uterine fibroids. They're usually benign until they become very highly perfused and they started bleeding, they end up having hysterectomy. The prevalence rate is usually seen between in ages 30 and 50, and it actually decreases with the menopause. One of the complications is hysterectomy. PCOS, very common in the clinic and also on exams. The 3 characteristic features are listed here. You have to memorize this and understand this very carefully. There is hyperandrogenism and insulin resistance, androgen hormones. Think androgen hormones, okay? And this causes insulin resistance in patients. This is because of the dysfunction in hypothalamus, pituitary, and ovarian axis. They also has a familial aggregation and heritability, and there are environmental factors also to be considered. Here's an article that I reviewed this for detailed information if you would like to read on that. The key points here is the hyperandrogenic state, as I said earlier. There is glucose intolerance and insulin resistance, and there's also hyperinsulinemia. They often run parallel and aggravate the hyperandrogenic state, gives you the symptoms of signs and symptoms of PCOS. Obesity adds to, and so think when a young female is obese and they have androgenic related signs and symptoms, and they complain about diabetes or insulin resistant type of signs and symptoms, excessive thirst, excessive hunger. They think they have diabetes and they have abnormal blood sugars, and you want to consider these hormonal testing. And vaginal yeast infection, one of the common things that you will see in the clinic with patients who undergo antibiotic use or their immune system is low, they went through chemotherapy. It's important to know what causes this and how do you treat them. And common vaginal infections that you will see on board exams are listed here. Vaginal candida, the differentiating signs and symptoms, odorless, curd-like, clumpy discharge, and how do you treat them. Key point is vaginosis is bacterial and yeast infection is, of course, fungal. So study the highlighted area, pay attention to the treatments and the different types of discharge you will see to distinguish the candida with other vaginal infections. Atrophic vaginitis and vulvar vestibulitis. You'll see these in board exams. Atrophic vaginitis is because of the lack of estrogen. The patients who have dyspareunia, occasional bleeding, and they have a pH 5 to 7. Vestibulitis causes also similar pain in the vulvovaginal area, but usually have burning sensation when they urinate, They have increased sensitivity to skin in the pelvic area, especially during exercise and when wearing tight clothing. They have burning sensation causing vaginal discharge, causing burning sensation, and an inconsistent pain, especially during sex. The two common STDs that you will see is gonorrhea and chlamydia. So I have created multiple slides on those. Pelvic inflammatory disease is another one that you'll see caused by sexually transmitted disease. Chlamydia and gonorrhea are the two precursors on those, like we discussed earlier in the slide. Chlamydia trachomatis is the bacteria that causes chlamydia. They enter the peritoneal cavity through fallopian tube, and sometimes they even causes peritonitis in untreated cases. So pay attention to all the highlighted areas that you will see questions related to that on board exams. This slide gives you the symptoms and long-term effects of the type of STDs that you have to know: chlamydia, gonorrhea, syphilis, trichomoniasis, HSV, and HPV. Bacterial vaginosis and trichomoniasis. These are STDs, of course, caused by sexual intercourse, and a parasite is the reason. The clinical features study the difference in the drainage description: greenish yellow, frothy, and this is a fishy odor, off-white discharge in bacterial vaginosis. Trichomoniasis is greenish, yellow, and frothy. This was already mentioned. I'm repeating the sentence because you'll see this on exams. And that concludes the questions or the pathophysiological and pharmacological clinical features of the types of disorders that you will see on questions in the NCLEX-RN and APRN levels. You will have questions that is related to perimenopausal, premenopausal syndrome. Pay attention to the type of diet, the non-medical therapies, the type of antibiotics that we use for each of them, patients who had pap smears, and what type of cells with bacteria you would see on those that will concern you of abnormal findings on the pap smears. And make sure you understand that you have to teach patients on good sexual habits. It's important to also differentiate the type of symptoms that causes PCOS in younger adults, because they come to you with all those signs and symptoms. So pay attention to each of these slides. I hope this will benefit you to understand the common diseases. As always, sending you these 4 comforting verses from the Holy Bible. God bless you and keep you safe. You will do fine. Stay positive and best of luck.